This is your lecture on adrenergics. I'm going to do a brief overview, but this should all be content that you are familiar with from physiology. So we do have our central nervous system and our peripheral nervous system. Our central nervous system is comprised of the brain and spinal cord, and then our peripheral nervous system is further divided by two divisions. We have our somatic and autonomic. Somatic is going to be our skeletal muscle and our voluntary. Autonomic is going to be broken down even further into our sympathetic, which is our adrenergic, and parasympathetic, which is our cholinergic. For this lecture, we are focusing on the adrenergics. Our adrenergics are going to be drugs that stimulate our sympathetic nervous system. So that is also considered adrenergic agonists and sympathomimetics. An important component of the sympathetic nervous system are our receptors. Right now we're focusing on the adrenergic receptors. We're focusing on our alpha, and we have alpha 1 and alpha 2. Beta, we have beta 1 and beta 2. And we also have dopaminergic receptors as well. Again, this should be very familiar from physiology, and if this is something that you're still struggling with, I would make the time to make sure you truly understand this. Because if you're giving a drug that's an alpha 1 agonist, we need to understand what is going to be affected and what we will see in our patient. Or if we're giving a beta blocker, what are we going to see based on what receptors are stimulated? One tip for the beta receptors to try to remember where, what, how everything happens. So beta 1, it affects the heart. We have one heart. Beta 2 affects primarily the lungs. We have two lungs. So beta 1 heart, beta 2 lungs. So our neurotransmitters can be inactivated in three ways. Reuptake of the transmitter back into the neuron through enzymatic transformation or degradation, which means breakdown, and diffusion away from the receptor. So we have two enzymes that are going to inactivate norepinephrine, which is our primary neurotransmitter. That's monoamine oxidase, which is inside the neuron, and then catechol O-methyltransferase, COMT, which is also located outside of the neuron. The exogenous drugs that we are talking about, they either work in two ways to prolong the action of the neurotransmitters. It's either by inhibiting norepinephrine reuptake, which makes more in the system and longer, or inhibiting the breakdown of norepinephrine through enzymatic action. Now we're going to dive into catecholamines and non-catecholamines. Catecholamines are hormones that are made by our adrenal glands. They're going to be released in response to any sort of physical or emotional stress. Our catecholamines are going to be epinephrine, norepinephrine, isoproterenol, dobutamine, and dopamine. Then we have our non-catecholamines. Those are compounds that lack the catechol hydroxyl group, so that makes it have a longer half-life because they don't become inactivated by COMT. So with catecholamines, they have a very short duration. They cannot be taken orally because they do not cross the blood-brain barrier, and they do produce a sympathomimetic response. So if we say that they cannot be taken orally, that means we have to think of another way. So what would you think? Intravenous. And with epinephrine, there are other ways we can give that as well. Either inhalation, we can actually give that through an endotracheal tube. We can also give that intraosseously or subcutaneous. Your non-catecholamines, as I had said, have a longer duration. So that's a very big difference between our catecholamines, and they stimulate our adrenergic receptors. An example of our non-catecholamines, ephedrine, phenylephrine, albuterol. And I really like this slide because it shows the difference between your drugs with the catecholamines and non-catecholamines and which receptors are going to be activated with each drug. When we look at our adrenergics and the mechanism of action, we're going back to that fight or flight response. So stimulation of our alpha adrenergic receptors is going to result in vasoconstriction of our blood vessels that then increases the amount of blood returning to the heart, increases our blood pressure and our heart rate, allowing us to run and fight for our life. Relaxation of our GI smooth muscle, decreased motility because we don't need to be worried about digestion when we're fighting for our life. Constriction of our bladder. Do we need to be urinating while we're fighting for our life? Nope. So you're going to have constriction, meaning you're going to be retaining urine. Contraction of the uterus, male ejaculation, and contraction of our pupillary muscles. So that basically means dilated pupils. And the fancy way to say that, mydriasis. I included these pictures because I thought it was a really great depiction of the fight or flight response. So on the far left, that was actually me in nursing school during a simulation, and majority of you are not in nursing school yet, but when you're in nursing school, every semester you have a simulation. And I just happened to be made the primary nurse, which meant I was in charge, and I'm pretty sure my heart rate was like 200, and it was so nerve-wracking, just being kind of put on the spot. So I thought that was a good picture. The next is my nephew having a moment with Santa. So fight or flight, because he would love to have run away from Santa. And then that was actually me skydiving. Huge fight or flight response. Not sure why people jump out of a perfectly good plane, but I guess I decided to do that. And then on the far right is that it really is called Bali swing. That was in Indonesia when I was there, and it was brand new. They were asking people, because they really hadn't started their business yet, if we wanted to get on a swing really high up in the air and just swing over the rainforest. And I thought, sure, why not? That sounds like a great idea. Retrospectively thinking about it, maybe not the best idea, but it was a lot of fun. But definitely fight or flight response when you're swinging over the rainforest really high up in the air in a third world country, and very little safety measures keeping you safe. But just a good depiction of our fight or flight response. Another important component of knowing what is going to happen when certain receptors are stimulated is the stimulation of our beta 1 adrenergic receptors, specifically in the myocardium, so in our heart. So our AV node, atrioventricular, our SA node, sinoatrial, and what happens when that's stimulated. These are important things to note, so you should be aware that there is an increased force of contraction, and that means positive inotropy. An increase in our heart rate, which is positive chronotropy, and then an increase in our conduction through that AV node, and that is positive dromotropic. So when we look at our indications, we're going to break this down by some body systems to help it make a little bit more sense. Starting with respiratory. So if we have a patient that has asthma and they're suffering from bronchoconstriction, our goal would be to create bronchodilation. So what we would do is give a medication that's going to dilate the lungs. So we want to stimulate those beta 2 receptors, because remember, beta 2 lungs. That's going to then cause bronchodilation and help that patient breathe. So some examples of those medications: albuterol, epinephrine, formoterol, levobuterol, and metoprolol. Then we have our nasal decongestants. So how those are going to work in response to adrenergic agonist response is through constriction of dilated arterioles, because what happens when you have a runny nose is not vasoconstriction, it's vasodilation. So when we constrict, we then reduce the amount of blood flow that then decreases the congestion. We also have ophthalmic indications, so that can relieve if there's any sort of congestion in the conjunctival sacs, or reducing intraocular pressure and dilating our pupils. We can also use this category for overactive bladders, so it's going to relax the detrusor muscle. because the function of the detrusor muscle is to contract during urination to help evacuate the urine outside of the bladder and into the urethra. It can also help with increasing the storage capacity of the bladder. And then a very large part of our adrenergic agonists are for cardiovascular indications. We may also utilize cardioselective sympathomimetics. We can use those for patients that have heart failure, whether they're in cardiogenic shock. And a lot of times we use vasopressor agents in the intensive care setting, not just for patients in heart failure or cardiogenic shock, but also septic shock or hypovolemic shock if the patient is severely critical and not responding to fluids. When we think of our contraindications and adverse effects, the overarching thing that I think is most important to remember is think about what we are stimulating. If we're stimulating our adrenergic receptors and we're aiming to increase heart rate, increase blood pressure, then what are the negative things that can occur due to that? So we should be worried about tachycardia, hypertension. If we're increasing our fight or flight response, we may have palpitations or chest pain. And one major thing we need to watch for is if we're causing vasoconstriction, which is going to increase our blood pressure, that can also increase our risk of a stroke. So that could cause a hemorrhagic stroke if we're having that much more pressure put on our vessels. So we need to be very cautious of that. We can also cause seizures. So if that does occur, we would have to give a sympatholytic. So lytic means to kill. So we would have to break up the sympathetic response. We should also be very mindful of other medications that we're giving that can cause potentiation of the effects of the sympathetic nervous system, especially our MAO inhibitors, antihistamines, and thyroid preparations we need to be very mindful of. We also need to take consideration that our alpha adrenergics can increase serum levels of our adrenocorticotropic hormone, corticosteroids, and our serum blood glucose. Now we're jumping into our adrenergic agents, and we're starting with our vasoactive medications. When we talk about vasoactive medications, these are drugs that are going to influence the homeostasis of our tissue oxygenation. Very commonly used drugs in the intensive care setting. If our patient comes in with an extremely low blood pressure, we say that we're starting a pressor, which is a vasopressor. I included this chart. I thought it was a really great depiction of showing what receptors you're going to see, what the effects on the heart, your system, your cardiac output. So it's a really great way to show a comparison. And I actually give our new grads this same chart before they start in the unit. The first drug we're going to talk about is dobutamine. Dobutamine is a beta-1 selective vasoactive adrenergic that is structurally similar to our naturally endogenous catecholamine dopamine. So it's going to stimulate our beta-1 receptors in the myocardium, which is then going to increase our cardiac output through increase of contractility. So can you remember what that would be called? If you're thinking positive inotropy, you are correct. So that's then going to increase our stroke volume, which will then increase our circulating volume. This can be especially helpful in our patients that have heart failure. It is going to be a continuous IV infusion. This cannot be given PO. And your clue for that is it is a catecholamine. Our next drug, dopamine, is a catecholamine. So if I'm telling you it's a catecholamine, what does that mean? It cannot be given PO and only be administered intravenously. It is a very potent dopaminergic, and it has beta-1 and alpha-1 receptor activity responses. Dopamine is one of those unique drugs that what you see is going to also be based on the dose that you give. So if we give it at a low dose, we can dilate our blood vessels that is going to be in the brain, heart, kidneys, and our mesentery. So it's going to help increase blood flow. So sometimes what we'll do if there's a patient that has, let's say, low urine output and we're not really sure what's going on, we'll do a low fixed rate of dopamine. And we do also call it DOPA. So if you hear somebody say we're starting them on DOPA, that's dopamine. So for example, the doctor will say, why don't you put them on a fixed rate of 2 mics, which would be micrograms, just to help with renal perfusion. And so it's not necessarily for their blood pressure, but to try to increase that renal perfusion and increase their urine output. In higher doses, it can either be for improving the contractility of our heart, so our beta 1, and then in the highest doses, it's for complete vasoconstriction, and those are for your patients that are going to be extremely hypotensive. So the overarching takeaway is going to be what receptor you see is really based on the dose that you give. Our next drug, very widely known, epinephrine. You may also hear it referred to as adrenaline. It is an endogenous vasoactive catecholamine. So again, catecholamine, what does that tell you? Cannot be taken PO because it will be degraded and can't cross the blood-brain barrier if it's given PO. So it's going to act on both of our alpha and beta receptors that are innervated through the sympathetic nervous system. This is our prototype for an adrenergic agonist. Most commonly, this is going to be for emergency situations. So it could be for cardiac arrest. So somebody goes into asystole. It's also part of our advanced cardiac life support algorithm. We can also give this if the patient is in shock and our other vasopressors don't work. Typically speaking, epinephrine is not our first line vasopressor when a patient is in shock. It's going to be our first line agent if the patient is in cardiac arrest. I included a picture of, looks like a cartoon with their heart beating out of their chest. That's what it feels like. You're putting that sympathetic nervous system into overdrive. So if that patient is awake, they're going to feel very out of their body. They're going to have palpitations. They're going to be tachycardic. They're going to feel very uncomfortable. We are purposely doing that because we're trying to increase their blood pressure and keep them alive, but it doesn't come without effects. So just something to be mindful of. Your patient may become very anxious because of those side effects. Our next drug, midodrine or proamotine, is an alpha-1 adrenergic receptor stimulator. It works by constricting arterioles and veins that result in peripheral vasoconstriction, which will then increase your blood pressure. We use this for patients with symptomatic orthostatic hypotension. So let's give some examples. A patient comes into the ICU. They're also put on a vasopressor because their blood pressure is low. An example, one we'll talk about in just a minute, norepinephrine or Levophed. So patients, if they're on vasopressors, they have to stay in the ICU no matter what. So let's say the patient's on a very low dose. It's not much, but they need it to sustain that blood pressure above, let's say, 90. So to help them achieve the goal of coming off of the Levophed or norepinephrine, we can start midodrine to help increase that blood pressure and titrate completely off of the norepinephrine. That is another way we use midodrine in the acute care setting. But people are very commonly on this that do have low blood pressure to help try to increase it as much as possible. However, we have to be very mindful that we're giving a medication that's going to cause vasoconstriction and increase their blood pressure. So, what do we need to watch for? Hypertension. This could get to the point where maybe the patient's blood pressure has normalized and now they're hypertensive. We still need to make sure that they're checking their blood pressure and making sure that it's appropriate to take it. We do also want to make sure that they don't take it within 4 hours of bedtime or after 6 p.m. because of the risk of supine hypertension. Our next medication, norepinephrine or Levophed. Very commonly used in the intensive care setting. This used to also be called Levophed, leave 'em dead. Very commonly the first line vasopressor that we'll use, except in our cardiac patients, because this can also cause right ventricular strain. So your patients that already have a cardiac history just need to be mindful of it. So, norepinephrine is going to stimulate our alpha adrenergic receptors, causing vasoconstriction. It has direct stimulating beta adrenergic effects on the heart, but no stimulation to our beta 2 receptors of the lung. So, it's not going to have an impact and cause bronchodilation. Most commonly, hypotension and shock are the reasons we would use Levophed, but really any reason that the patient has consistently low blood pressure. It is continuous infusion. It is not something oral. This is something they absolutely have to be in the intensive care setting for. You might also hear this medication called Levo. That's what we commonly call it. Typically, we don't say norepinephrine. You may hear norepi, but most commonly, you'll hear this drug referred to as Levo. Our last medication, phenylephrine or neosynephrine. This works exclusively almost on our alpha adrenergic receptors. For the most part, this is intravenous. However, we do have nasal spray, which you'll see very commonly, and that's also why I included a picture. And there can be some over-the-counter formularies. For our purposes, we're just going to be focusing on the intravenous route as well as the intranasal. When it's intravenous, we're using this for hypotension. Very short term. Again, it's a continuous infusion and the patient has to be in the intensive care setting. We can also use this to control supraventricular tachycardias, vasoconstriction in regional anesthesia, as well as ophthalmic uses. Most commonly, you'll hear it for hypotension and as a nasal spray for decongestion. Something to think about. So if we're giving neosynephrine as a nasal spray, our goal is to cause what? Vasoconstriction, right? So predominantly your symptoms of congestion are going to be from vasodilation. So we need to constrict so that we can shunt that blood and reduce the congestion. Well, what else could that possibly cause? High blood pressure. So I'll give you a story from when I was a new grad and something that was very impressionable and I never forgot. I had a patient who was there for something very unrelated to a cardiac or respiratory problem. And they were saying that they had a lot of congestion and they were so uncomfortable they couldn't sleep. They said, is there any way, could we order something just to help? I'm so miserable. And some formulary names for neosynephrine, also Afrin. So I thought, yeah, you know what, I'll call the doctor and see if we can get you something because you're very uncomfortable and, I want you to be able to sleep. So I called the doctor and I gave an SBAR, so situation, background, assessment, and recommendation. And I said, the patient's got a lot of nasal congestion. They're very uncomfortable. They're having a really hard time sleeping. Is there any way we could have something like Afrin or a neosynephrine nasal spray to help with their symptoms? And the doctor says, don't they have a history of hypertension? And aren't they on medication for high blood pressure? And I said, yeah. I'm like, oh yeah, that's going to cause an increase in their blood pressure. So I can't give that. And I said, okay, never mind. It was a really great takeaway that even something that we think is so minor and simple as a nasal spray could really affect the patient. So we didn't order it and we had to do other supportive measures to help the patient feel more comfortable, but we couldn't give it because they had high blood pressure. So learn from my mistakes. Never give a patient nasal spray neosynephrine if they have high blood pressure.